if we could move on to our next speaker, is George Mascaro, who, as I said earlier, has taken on the big shoes left behind by Professor Bonza in Birmingham, and I'm looking forward to his talk on the principles of redo aortic root surgery.
Thanks, Jeff. First of all, I would like to thank the Society for the invitation to come in and talk about this big topic, which is how to face and how to approach redo root surgery. When I was preparing this talk, I was amazed, surprised that in actual fact, when we redo the aortic root, it's not just, or when we re-enter the chest in aortic surgery, it's not only to redo the aortic root, but it's a whole field and it's a whole complexity of features that we need to face. If we do a little bit of history, we will see that the first aortic valve replacement with a replacement of the ascending aorta was done in 1964. Following this, in 1968, Benthal and De Bono, they developed the technique for root replacement. And since then, aortic surgery has experienced probably a boom. Surgery of the proximal aorta has steadily increased. There is an expected mortality for first-time operations, which is quite low, less than 5%. And root replacement has become actually a reproducible procedure with low morbidity and low mortality as it is expected. In this presentation from circulation and looking at experience, 30 years experience in aortic surgery of the aortic root, 200 patients are presented undergoing aortic root replacement. None of them underwent arch replacement, low mortality, and low rate of neurological complications. However, the literature indicates as well that there are some worsening or worst outcomes amongst patients with added problems, which is what we see nowadays. Patients with non-elective presentations have worse outcomes. Patients with previous cardiac surgery or patients requiring additional procedures, all of them represent higher risk patients and indeed with worst outcomes. Contemporary results in aortic valve replacement in North America, and this is a paper presented in 2012, showed what we see here. Specifically, what I wanted to highlight is those patients undergoing non-elective procedures have definitely higher mortality and worse outcomes. And the more complex the procedure, the higher the mortality and the complications are. Increasing the number of first-time operations will lead definitely to more reoperations. And as Dr. Miller was just saying, we are doing these days more valve-sparing root replacements, and we don't know, for example, how long they will last. And we need to have a clear approach on how are we going to deal with these redo operations in the future. Surgery then of the proximal thoracic aorta is rising. We operate on more type A aortic dissection these days. We don't know, in some cases, how to deal with the false lumen that we left behind in the aortic arch or even in the descending aorta. And although this is not necessarily part of the title of the presentation. When we deal with the aortic arch, we need to deal with it from the front, and we need to have clear strategies on how we are going to operate on the aortic arch. We're operating more on patients with connective tissue disorders. Again, the same situation. Valve replacement is increasing. Aortic valve replacement is a well-established technique, and undoubtedly some of those patients will develop infective endocarditis and will require redo operations. Valve sparing techniques, as we just mentioning as well, we don't know the longevity and how long for the valve is going to be functional, and in the future, most probably those patients will require as well a redo operation. The use of homografts and autografts, increasing use of bioprosthesis as well, and the natural degeneration of those bioprosthesis will require some special attention. It is somehow estimated that probably about as much as 10%, and I think probably it's going to be more, of aortic surgery will be represented by reoperations of the ascending aorta. So what have we got in the literature? What is the evidence in the literature about this new entity that is coming and redo of the ascending aorta? In this presentation from Di Bartolomeo in Bologna, they studied their own series of 174 patients undergoing reoperation of the ascending aorta. The mortality, as we see, is now considerably higher than in first-time operations, with a higher rate of stroke and other complications as well. The main indications for reoperations of in the ascending aorta is given by degenerative aneurysms in 50% of the cases, post-dissection aneurysms 26%, acute type A dissection, pseudoaneurysms, and this is a problem that we are seeing quite frequently, more and more, 12% in their series, and infective endocarditis 6.3%. The patients, as I was mentioning before, are complex, and the complexity of the patients is represented in this table, and this is from the same paper from Di Bartolomeo. The first-time operation is presented here on the right, and on the left, and on the right is represented the operation that the patient underwent at the redo time. Most patients underwent for the first time just a simple aortic valve replacement. However, they in the redo setting, the operation was much more complex than just going to do a redo operation. And that's mainly what I wanted to show here in this with this table. Is the complexity of the procedure is not as simple as we may believe. From the group of Dr. Bavaria, preoperative aortic root replacement in patients with previous aortic surgery, we see exactly very similar outcomes. 156 patients underwent reoperative procedures of the aortic root surgery. From them, 39.7% had reoperations as well, or the reoperation included the aortic arch. The 30-day mortality is 11.5%, and that's showing us how big a risk the patients face. Post-operative neurological morbidity is 3.2% higher than in first-time operations. Again, Di Bartolomeo extending in his series Now presenting in a new presentation, 224 reoperations. Still, mortality is 12%, and here they extended in longer follow-up at 1, 5, 10 years with survival rates of 95, 90%, and 81%, saying the operation is doable. However, the initial mortality and the initial risk of the patient is high. The pattern and the distribution of the indications for surgery remains relatively similar, with degenerative aneurysms, chronic dissection, post-dissection aneurysms, acute type A dissections, in a redo setting, pseudoaneurysms, infective endocarditis, and they have here one patient with a iatrogenic supravalvular stenosis. These patients, generally, when they come to the operating table, they do need some additional procedures. And coronary artery bypass grafting, valve replacements or repair, combination of coronary artery bypass grafting, aortic aneurysms, and reduced sternotomies is not uncommon. What do we have and what have we seen in our own experience in Birmingham? And we reviewed our numbers between 1998 to 2013. We have done 511 aortic root procedures, from which 144 have had some type of previous cardiac operation. The cohort of patients is complex, and some of their details can be seen here. The distribution of patients: 76% of the patients were male, 51 years of age in average. More than one previous operation in this whole group was 23%. Other comorbidities include coronary artery disease, COPD, renal failure, some extracardiac arteriopathy, and previous strokes or TIAs. The problem is when these patients, one of the problems is when these patients come in an acute setting. And from all the 144 patients that we have reoperated so far, 48% represent urgent or emergency cases. I have to say that the urgent cases, some of this is patients with endocarditis, unstable. They're not necessarily an emergency, but because of uncontrolled endocarditis, uncontrolled sepsis, the patients had to be operated sooner rather than later. Rupture of an aneurysm in 5.1% of the cases, and the patients, 5.5% of patients have come to the operating table ventilated and on some type of inotropic support. Added procedures that that the patients had required: 14% of the patients required coronary artery bypass grafting, procedures into the arch, 23%, and all these operations are long operations. Cardiopulmonary bypass time, 268 minutes, and cross-clamp time has been on average 165 minutes. What are the results that we can show in this group of patients? Hospital mortality around 16%, low incidence of stroke, only 1.4%, and some patients with some neurological deficit, temporary neurological deficit, 2.1%. The need of post-operative filtration, 7%. None of the patients have presented any myocardial infarction. 4.8% of the patients have required prolonged ventilations and tracheostomy, and reoperations for bleeding is what I believe actually low, only at 11%. What have we learned so far? Patients undergoing redo operations of the ascending aorta, and not necessarily just the root, is a difficult group of patients, generally associated with comorbidities. Almost half of them require an additional procedure. The mortality is considerably higher than the first-time operation. The most common indications remain as aneurysms, false or pseudoaneurysms, patients with infective endocarditis. What approach have we took in Birmingham, and how to achieve some reduction of all the risks and improve the results, and how to make it a safer operation? We have an established MDT where all cases get discussed, and it's a very strict decision-making process is applied for the need of an operation or no need of an operation. A patient develops a pseudoaneurysm, not necessarily because the patient has developed pseudoaneurysm, will require an immediate operation. We monitor the pseudoaneurysm. If the pseudoaneurysm is growing and reaches size of difficulty or reaches a size of danger, then we advise the operation. Imaging support in these patients is vital. CT scans of the aorta, echocardiography, transesophageal echocardiogram needs to be part of the support in all of these patients. Probably one of the most important topics, or one of the most important aspects in a redo surgery of the ascending aorta, is to plan your operation. It is paramount to time the reduced, when to do this reduced sternotomy. Need to have a well-planned and decided site of arterial cannulation, technique for venous cannulation, technique of cardiopulmonary bypass. Some patients will do with moderate hypothermia. Other patients will require deep hypothermic circulatory arrest. What is what we do in Birmingham? This will be probably controversial, but is the way we do. If it is a redo operation, we institute cardiopulmonary bypass always, 100% of the cases, before opening the chest. This since I took over of the aortic program in 2011. Cannulation site, we have different choices. Femoral artery, most of the time, is what we do, but also we use the right subclavian artery if the patient is not unstable and if there is time to dissect the right subclavian. The femoral vein is exposed as well with a long double-stage cannula. We establish venous drainage. We initiate then cardiopulmonary bypass at moderate hypothermia, 32 degrees, and then we open the chest and we do the whole dissection of the heart at that with the support of bypass. It gives us security, and in case we breach any of the major structures, we are already at with some degree of safety. If there is a risk, an anticipated risk of breaching a pseudoaneurysm or the aorta in itself during the opening procedure, then we initiate a bypass the way I have described, either fem-fem bypass or via the right subclavian artery. Then we do a small left anterior thoracotomy to vent the left ventricle, and then we cool the patient down to 22 degrees. At 22 degrees, we open and we do the sternotomy, and we do then completion of the dissection and everything else. We always use cardioplegia. We believe organ protection is paramount and myocardial protection is paramount. Even in deep hypothermic circulatory arrest, we administer cardioplegia at a specific period of time. And if deep hypothermic circulatory arrest is required, we always use selective antegrade cerebral perfusion. When we break down our series of redo operations from 144 patients that we did, and when we break it down by era, since 2010 to 2013, we find that we've got 46 patients undergoing redo root or redo ascending aorta replacement. 22% of these patients has an associated procedure to the arch. 11% of the patients have an associated coronary artery bypass graft. With the approach that I have described, the mortality of this patient has reduced to 4.5%, and we have an incidence of 0% of stroke. 2.3%, however, of the patient do develop some temporary neurological deficit. What is from my point of view, your takeaway message? Redo surgery of the proximal aorta is on the rise and may account for up to 10% or more of aortic procedures. Principal indications are aneurysms, true or false, and within the true, degenerative or post-dissection aneurysms. Aortic stenosis and aortic incompetence are part of the indications because these patients that have undergone previous aortic valve replacements will, one way or the other, some of them require redo aortic procedures. And the dysfunction of prosthetic valves is an indication that cannot be underestimated. Appropriate preoperative planning is absolutely necessary with imaging. And probably I would like to insist here that much of the success of the operation is based on a safe reduced sternotomy, adequate myocardial protection, adequate brain protection, adequate visceral protection, and in cases of patients undergoing redo surgery for infective endocarditis, extensive debridement of the root and of the annulus. Thank you very much.
George, thank you very much for that. That's very interesting. Perhaps I can start by asking the first question. Do you think we can reduce the number of redos if we're more aggressive in our primary operation, for instance, the dissections, to go into the arch more, or in degenerative aneurysm disease, say, if there's a slightly borderline arch, to take out the ascending aorta root and then go into the arch? Do you think it's worth increasing the risk of the primary operation to reduce the redo and hence mitigate the high risk redo? Although your results are very good, 4.5% for redo aortic root surgery is pretty impressive.
I think that's a very controversial point. And I think if the operation is done in hands of people that are aortic surgeons and that are familiar with the technique, probably I would say yes. If you treat not just the type A dissection, but if you also treat the arch and the and eventually the proximal descending aorta, you may save some of these patients coming to a redo operation. However, we know that aortic dissection presents anywhere around in the country, and I think that probably nowadays any cardiac surgeon should be prepared to deal with it. And I don't expect that any cardiac surgeons should be dealing with the arch and the proximal descending aorta. I think what is going to kill the patient is the type A dissection, and that's what needs sorting.
Jonathan.
We've benefited from two extraordinary talks this morning from two very experienced surgeons indeed. I don't think you can get more experience in the room. My concern is this, that when I get my dissection or my root aneurysm, who's going to do this operation? You know, I think in the era, both here and in North America, of surgeon-specific mortality reporting, I really fear how we are going to train our young surgeons of the future. If I was a trainee coming out into the field now, I'd be very concerned taking on this sort of procedures that you guys are talking about. I've been in the job for 16 years and I'm taking on these roles, and I know that our cardiologists give us no leeway as a learning curve. I know that our hospital management is looking down our necks for our results, and I certainly know it's happening at a national level. So I'm interested in how you think we should be training our trainees who are coming to this meeting. I mean, we have a responsibility to make sure that they are safe and trained. And how do we do this in the current era? Because it's getting worse, not better.
I don't know, Jonathan. Is the answer to that. Yes, there is a trend to say this activity should be performed in specialized centers only, but that means that patient dissecting far out in the country, they need to be transported, and we don't know when that type A dissection is going to rupture. I don't know what the right answer is.
John.
I was intrigued that you go on bypass on all your redos. I have two questions for you. What if you have a CAT scan that shows the aorta is not vulnerable, which is usually the case? Would you still go on bypass? And my second question for you is, in what percentage of your cases did you actually take apart a root replacement with the buttons and everything and put in a new root replacement?
With regard to the first question, I have probably a little bit of a biased approach, and the reason for that is that I direct the transplant program as well, and in the transplant program, always generally we have a big heart, big right ventricle. Put the patient on bypass before opening the chest, and gives quite a nice and comfortable environment to do the whole procedure without disturbing the hemodynamic of that patient. And that is the reason why in almost every redo I do it that way. The second question, I don't have the exact answer to that. It's probably, however, I would say that it's probably about 25% of the cases where we've had to take the whole route down and redo with buttons and everything, and then redo it.
Perhaps we just have time for one more question because we are running a little bit late.
When you look at all these redos, most of the patients had previous operations like AVRs, large percentage of them. That probably means they're not that dissection patients. They're the patient who had a bicuspid aortic valve replaced with just purely valve alone and leaving the borderline size ascending aorta. For that kind of operation, we don't need a highly specialized service to provide AVR ascending aorta replacement. I think we just need to educate and train next generation, our trainees, and then provide with the specialist aortic training program, like aortic fellowships that we do. And maybe we should have more of those training programs across the country, supported by SAC in our kind of society, and then so that every year we'll produce a trainee coming out of training with specializing in this complex aortic surgery as well as normal trainees, cardiothoracic trainee, coming up with the knowledge and familiarity and practice of replacing ascending aorta and aortic root, which is not a highly complex aortic surgery. I think that probably will help, I think.
I think that's a very good point, and in fact, it leads me to introduction of our next speaker, who in fact was. Thank you very much, George.
That's right.
Who was in fact